We are going to talk about nephrotic syndrome, which is also known as minimal change nephrotic syndrome or minimal change syndrome. So the pathology of this is that it is the glomerular membrane gets really swollen and fat and becomes permeable to much larger substances like protein. Protein's a big fat substance, and it can then escape or drop or spill through the glomerular membrane of the kidney, and this leads to an overall loss of protein. And as you know, we need protein to live. Without good amounts of protein, we develop ascites, we develop what's called anasarca, which is just an overall swelling. Our vascular structure cannot hold on to its fluids, and it overloads our renal system. So there's 3 different types of nephrotic syndrome. There's a congenital type, a secondary type, which means it was caused by a medication or an illness or a disease. And then there is idiopathic, and we tend to see the idiopathic being quite common, and that one just literally means they don't know what's causing it. They do feel that it is in response to it's an autoimmune response to some sort of a viral process. So the risk factors for developing nephrotic syndrome is being a male, being born with intrauterine growth retardation, or being a very small birth weight. It usually occurs at ages 2 to 3 years, and 70% of cases occur before the age of 5. The cues that we see in these kiddos is nausea, vomiting, a very recent weight gain. They wake up with periorbital edema. Their faces are super swollen. Their eyes are almost swollen shut. They're very weak and fatigued, and they're highly irritable. All of these things are because they are basically dehydrated and malnourished. Their protein has been spilling into their urine, so they don't have protein in their body where they need it, and that also causes the fluids to shift out of the spaces where they're required to keep us functioning and into the interstitial spaces where they basically do nothing but make us feel horrible. These kids will also develop tachypnea and dyspnea because of the swelling. And we frequently see frothy urine. It's normal color, but it's frothy because of the amount of protein that's in it. Let me see. The diagnostics or labs that are done to prove these children have nephrotic syndrome is usually a urinalysis and some serum tests. So their urine always shows really high numbers of protein and very minimal to scant blood. Their serum shows a super, super low albumin and also hyperlipidemia. So they are filling up with lipids in response to the loss of protein. Their livers do some crazy things, and it causes hyperlipidemia to occur. These are the complications that we can see in a child who has minimal change nephrotic syndrome. They become anemic, and this can lead to other issues. They are more prone to infections. They have poor growth overall. They can develop peritonitis, and it is common to develop blood clots. Basically, they're at an increased risk for clotting because their intravascular volume is decreased and their blood is kind of dehydrated. So this puts them at a higher risk for a thrombotic event. They are also at risk for renal failure. And renal failure happens, unfortunately, when the steroids or immunosuppressants that we give them to treat the nephrotic syndrome stop working, or they become basically resistant to it. And then there's nothing that can be done after that other than for their kidneys to fail, or they need a transplant. So the medical management that we do on kids with nephrotic syndrome is usually long-term therapy using corticosteroids. Um, they'll also receive albumin via IV. And then we should always follow albumin with a diuretic like furosemide. So these kids are on steroids, albumin, diuretics frequently. There are some times with idiopathic um, nephrotic syndrome where the child really doesn't need any of these things. They might not need steroids, they might not need albumin, they might not need diuretics. We're just going to treat them with fluid restriction and sodium restriction and wait to see what happens. And if their swelling improves and their blood pressure doesn't become an issue, then we send them home. And it is likely to recur with periods of illness, though. So if a child is resistant to steroid treatment, then they'll be started on an immunosuppressant such as cyclophosphamide, cyclosporine, or mycophenolate. And this opens up a whole other can of worms for these kids because now not only are they at risk for increased infections just simply from the nephrotic syndrome and the malnourishment and the wasting that goes along with it, but also now because they're immunocompromised. So the actions that we have to take as nurses is first to promote diuresis. So we're going to, in the hospital setting, give them steroids, give them diuretics. We're going to monitor their weight daily, even though we do this for every pediatric patient regardless. We're also going to teach them as an outpatient, the family needs to monitor their weights daily. We're going to monitor their urine output. We're going to do dipsticks for protein, and we're going to assess the patient for edema that's worsening or improving. And most of the time, we're going to have to defer to the family members on that because if you go one day in between caring for a nephrotic syndrome child, you might miss so much that you see them and you don't realize they've gotten any better, but their mom does. For preventing infection, frequently these kids are going to have to be on prophylactic antibiotics, and they'll be on prophylaxis for sometimes their entire lives. We need to make sure that families know and caregivers that as long as a child is utilizing a corticosteroid, they cannot receive any live vaccines. So it's very important that everyone around the child is vaccinated appropriately, but the child cannot receive a live vaccine until 2 weeks after they stop the corticosteroids. They need to have immunizations such as the pneumococcal vaccine that's given every 5 years. We need to educate the family about chickenpox. So if they have not received the varicella vaccine, then are exposed to anyone with chickenpox, it is an emergency for them to need to contact the pediatrician or the nephrologist immediately so that they can then receive varicella zoster immunoglobulin so that their kidneys don't have further insult from the chickenpox. We want to make sure that they get adequate nutrition. So this means that during the edematous phase, they need to have restricted sodium and restricted fluids. Also, as long as they are spilling protein in their urine, we should restrict their fluids and their sodium. So we're running a really crazy balancing act because these kids are technically dehydrated, but we need to restrict fluids. So we really want to monitor urine output and daily weights very closely. We want to make sure that these kids receive a protein-rich diet, which is not always easy with the 2 and 3-year-old. They're not big meat eaters. If they are exposed to illness, such as just a simple flu or cold, their parents need to be educated that they need to do frequent temperature checks and urine dipsticks for protein. These kids might not be spilling protein their entire lives, but they're more likely to have the permeability of the glomerular membrane when their immune system is in overdrive. So when they are trying to fight off an illness, we're likely to see all of the same symptoms recur. So that's why the parents are going to do frequent temperature checks and urine dipsticks if they see a temperature over 100.4 and or any protein in the urine, then they need to contact their provider. And then we're also going to give emotional support. These caregivers are going to miss a lot of work, and the kids are going to miss a lot of school. And it's also very difficult because they develop moon face due to the prolonged steroid use, and that can be just devastating for some caregivers and patients. So that is nephrotic syndrome in a nutshell. I want you to really focus on the fact that their urine is frothy, that it is filled with protein, and that the child likely has a normal blood pressure, but has hyperlipidemia, hypoalbuminemia, and proteinuria. Those are good things to know about nephrotic syndrome.